Everyone. Hi, my name's Dr. Al Rundio, and I coordinate our PCSSO grant with the American Academy of Addiction Psychiatry. And this is our fourth webinar for this year. I'm happy to introduce Dr. Bill Lorman. You can see on the screen some of his credentials. Dr. Lorman is a past president of the International Nurses Society on Addictions. He also has a PhD in Freudian psychoanalysis, and he recently completed his law degree. His current job is Vice President and Chief Clinical Officer at the Livingren Foundation in Bensalem, Pennsylvania, which is a large addictions treatment facility. He also is a assistant clinical professor at Drexel University in Philadelphia and an adjunct professor in the Department of Psychology at Immaculata University, which is located outside Philadelphia. He also has completed the buprenorphine waiver training. He has his waiver, and he is a prescriber. So he is going to discuss today the CARA Act and the buprenorphine prescribing for advanced practice nurses and physician assistants. Bill, welcome, and we're glad to have you today.
Okay, thank you, and welcome everybody. Hopefully you'll find, you'll get some good information from this presentation, and you can be directed to several really good websites to help you along if you're interested in prescribing. So first thing I want to do is give a summary of the Comprehensive Addiction and Recovery Act, just some of the highlights. You know, there are other things in the Act. There are a lot of things in the Act, actually. I only have a few things listed here in which this Act covers. So it was, first of all, it was signed into law a little over a year ago, and it actually addresses the full continuum of care from primary prevention to recovery support. So the whole continuum is in there, and it includes criminal justice and law enforcement related provisions are also in the Act. So there are a couple specific sections I want to point out. Section 107 has to really do with naloxone, so improving access to overdose treatment and provision of grants to not only federally qualified health centers and but also opioid treatment programs, OTPs, and any particular practitioner who is waivered to prescribe buprenorphine can also apply for these grants. And what this part is really about is establishing naloxone co-prescription program and provide trainers and training to healthcare providers on naloxone co-prescribing, also training the end users for naloxone. The grants can also be used to purchase naloxone to give to audiences, and are offset co-payments for naloxone if the person has any, and establish protocols to connect patients who have experienced an overdose with appropriate treatment. And there are several programs, at least in my area here in Pennsylvania, in Bensalem, which have started to find appropriate treatment for these folks that are ODing, to provide naloxone to them and then get them into treatment. Another important section is Section 110, which provides grants to states to implement strategies for pharmacists to dispense naloxone pursuant to a standing order, which the individual states have to accommodate, and develop naloxone training materials for the public. So they're also doing that. And then we have Section 301, which awards grants to state substance abuse agencies, local government, nonprofit organizations in those areas with high rates or rapid increases in heroin or other opiate use, to expand availability of medication-assisted treatment. And it authorizes an awful lot of money for that intervention and doing that. Now, the one that we're most interested in is Section 303, medication and treatment addiction, medication for addiction treatment for recovery from addiction, medication-assisted treatment, I'm sorry. It expands prescribing privileges to us, NPs, physicians assistants, and the statute is for 5 years, so it ends October 1st, 2021, where it has to be renewed or theoretically we will lose our waiver if that should happen. And in order to prescribe buprenorphine, we have to, the NPs and PAs have to complete 24 hours of training to be eligible for the waiver to prescribe. And you have to be supervised by or work in a collaboration with a qualified physician if required by law. So if you're in a state in which you have full authority, then you don't have to be supervised or be in collaboration. If you're in a supervisory state, then supervision is required, and in a collaboration state, collaboration is required. Now, the interesting thing here is I can talk for Pennsylvania. In Pennsylvania, even though I'm a psych NP, my collaborator can be anybody. My collaborator can technically be an OBGYN for that matter. But if you are waivered to prescribe buprenorphine, you have to have a collaborative agreement with a physician who's already waivered. So that physician has to be waivered also in order to for you to prescribe buprenorphine. Additionally, several states have begun writing their own guidelines for NPs and PAs who want to prescribe. So making it a little more restrictive in what you can do, how much you can order, a bunch of other things that several states have already begun that process of doing so. You should first check with your board to find out whether or not there are any additional guidelines or restrictions for prescribing buprenorphine. And the American Academy of Addiction Psychiatry, as Dr. Rundio pointed out, in collaboration with the American Psychiatric Nurses Association, provides free training, which is totally online. So you can get all your 24 hours of training online for free. And then once you get your certificate, you can send it in and you'll get your waiver. Now, obviously, it's assumed that you already have a DEA license to prescribe controlled substances. If you don't have a DEA license, then you can't get the waiver. You have to first apply for your DEA license, and then when you apply for the waiver, they'll just add that to your DEA license. It doesn't cost anything additional to do that. And here's another important thing. It excludes, as far as the counts go, which I think is my next slide, it excludes from the patient limit those patients to whom medications are directly administered. So this is directly from the statute. So if you're working in an inpatient facility and you are prescribing buprenorphine, if you're waivered to prescribe buprenorphine for addictions, that doesn't count within your 30 patients. That's just for those patients that you're writing prescriptions for. And that's how the count will begin. So NPs and PAs are limited to 30 active patients at any given time. So you got to make sure that you are really good at your documenting your active patients. And when your patients are discharged, make sure that they are properly documented, because DEA does make unannounced visits and will want to see at your fingertips that you have documentation and that you're not going over more than 30 active patients in which you are seeing and prescribing buprenorphine for. And this restriction lasts for a minimum of a year, and after that period of time you can apply for an additional 70 patients, or for a total of 100 active patients at any given time in your practice. So every time we get a new controlled substance, the FDA requires a risk evaluation and mitigation strategies to ensure safe use, for which, most folks think, well, that's the pharmaceutical people that have to provide that. But included is documentation that we have to provide. So, for instance, what you have to document, all these things that I've listed here, you have to verify first that the patient, in fact, does meet diagnostic criteria for opiate use disorder. Now, just a simple statement saying patient meets criteria technically is enough. You should probably utilize a checklist, especially if you're not working in addictions. If you're in primary care or something, you should utilize a checklist which lists the DSM-5 criteria, so that you can be able to adequately demonstrate that, in fact, the person does meet criteria for opiate use disorder. You have to document that you've discussed the risks, including misuse and abuse, along with the side effects associated with any buprenorphine-containing products, and then explaining what patients should do if they do experience side effects. So that also has to be very much included. And as another pearl, after you've documented all of this, that you've spoken to the patient, it's probably best legally for you to, and probably best practices, to also state that patient understands the discussion. So you really should do that, because sometimes a patient will come back and say, well, you never explained it, and if you did, I didn't understand it. But if you documented that, obviously you're more credible than the patient when it comes to if somebody should decide to do anything, take any legal action. Provide induction doses under appropriate supervision. Now, what that means, now don't think that means that you have to be supervised when you're providing induction doses. What that means is that the patient should be supervised. So I know when buprenorphine maintenance induction first came out, one of the models was to just call in the prescription to the pharmacy. The patient would pick it up and go home and do the induction themselves, and then call you that day or the next day. That was one of the models that's used. And there are still some folks that utilize that. It's probably bad practice to do that. The patient should be in front of you when you're giving the initial doses. Prescribe a limited amount of medication to the patient that will last until the next visit. So I do have some slides that will talk about one model of induction, and you shouldn't give them like a whole month's supply during the induction phase. You should only give them enough, or give them a prescription for enough until they come in next, whenever that's going to be. Prescribe a limited amount. I already did that one. Explain how to safely store the medication out of reach of children. So there have been instances in which infants and toddlers have gotten into their parents' or siblings' supply of buprenorphine and have actually died as a result. So that's one of the reasons why we now see special packaging for this. But you should also actively explain how to store the medication out of reach of children, not leaving it out, most important. And again, documenting that. Schedule patient appointments commensurate with their stability. So that's a general statement that's in there just as a guide. At least for the first month, the recommended schedule is weekly or more frequently, depending on how stable the patient actually is. And when you're looking at stability, you're looking at psychosocial, environmental issues too around that. Some people consider a pill or film count or other dose reconciliation method. Working in addictions, I know that our patients can easily figure out ways to trick us in film counts and that type of thing. Assess whether the patient is receiving the counseling or psychosocial support considered necessary for treatment, and if not, encourage them to do so. In my own practice, at least for the first year, I pretty much require patients to be in therapy while they're on the medication to address issues related to their addiction and to their environment and to their stage of change and all of that. Other folks just make it a recommendation or a strong recommendation. And in fact, the statute does say that all you have to do is recommend it. Patients don't. It's not mandatory. If you want to make it mandatory, certainly you can. That's entirely up to you. But you have to at least document that you have told the patient to strongly consider psychotherapy. And don't just say that. It's probably best bet for you to give them the name of some folks where they can go. Now, one of the things that I do is I send my patients to specific therapists who maintain good communication with me with the patient. So for those patients that have down the line that will be treated for longer than 3 months, and you're only seeing them once every month or every 2 months or every 3 months, whatever it is, you can maintain tabs with their therapists as to how they're doing and that type of thing. Assess whether the patient's making progress towards treatment goals, including as appropriate urine drug screens. There should always be treatment goals when patients are starting any type of treatment, including buprenorphine, and they should be focused, they should be reasonable, they should be attainable, and you should be, every time you see the patient, to see what progress actually has been made. So that pretty much is most important. Also for your documentation and to assure. So our patients can very easily divert their medication. They can sell it. They can sell half of it so that there's always 50% in their body. So when you do a urine drug screen, it's going to, a qualitative is going to show positive, and they could be selling it. And there's all kinds of ways of getting around. They could be buying even more. So the issue isn't whether or not they're taking their medication as prescribed, although that's a very important consideration. You really want to see behavioral changes in the patient as they progress. So the medication is there. Medication-assisted treatment is there so that the patient can progress in the quality of their life. And that's really what you should be measuring. If you're not seeing that, that's very problematic. And that's usually the first sign that something's wrong. By the time you figure out that they're either selling all of their medication or using extra or misusing it or whatever, that's already too late. You're going to be seeing the process of them going downhill. That's what you want to be able to catch. Continually assess appropriateness of the maintenance dose. So basically, what we talk to the patient about is their cravings. So we utilize the strong correlation of cravings to relapse. So if we can extinguish the physiologic cravings that the patient is having, then their risk of relapse has decreased significantly. So that always has to be on the conversation when we're talking to our patients about how they're doing, is about whether or not they're having any cravings, in addition to any other side effects of the medication like drowsiness, that type of thing. And then we continually assess whether or not benefits of treatment outweigh the risks. So that you're always looking at, as I say, when you're identifying with your patient their treatment goals, the accomplishment of their goals, any side effects that they're having, how you're dealing with side effects, all of that type of thing. Now, there are some serious risks that we have to make sure that we not only communicate but also document. For instance, accidental or deliberate ingestion by a child, which can cause respiratory depression, which leads to death. If a child is exposed to one of these products, medical attention should be sought immediately. You need to be very specific. If there are children in the house or may have access to the medication, what the person should do. It's extremely dangerous to self-administer non-prescribed benzos or other central nervous system depressants. So you're going to talk to them about that, including alcohol. And if controlled substances are prescribed, they should only be used as directed. And once again, that even, obviously somebody that has an addiction, we want to make sure that we're not creating a cross addiction with another controlled substance. So be very, very careful if other controlled substances are prescribed. And if you're not an addiction specialist, if the patient is on other prescribed psychoactive medications, then it's probably best handled by an addiction specialist. It could get a little hairy sometimes, and trying to figure out, if you're seeing side effects, what's actually causing them, or drug-drug interactions. Now, we generally don't see drug-drug interactions with buprenorphine. It's very possible, though, that you could, but there can be a synergistic or additive effect of other controlled substances with the buprenorphine. Never give these products to anyone else, even if he or she has the same signs and symptoms. most important to tell them that. What a lot of folks do is have a written checklist that they give to their patients that has all this information on. And you give them a copy, and if you want, if you have hard copy charts, have them sign a copy that they received a copy and put it in their chart. At my place, we have electronic health records, so we already have that incorporated into the forms in which they can electronically sign that they've received a hard copy of that. And then selling or giving away buprenorphine-containing products is against the law. So all of these things can be on your on your checklist or contract or whatever it is that you want to have. If a patient continues to abuse various drugs or is unresponsive to treatment, including psychosocial intervention, it's important that you assess the need to refer to a specialist or a more intensive level of care. So remember, you're always looking for progress in treatment, and you're always questioning if the patient is unresponsive. You got to be real careful. Basically, and we'll talk about 16 milligrams of Suboxone is the standard that, and with 16 milligrams statistically saturates 95% of the mu opiate receptors in the brain. So theoretically, that should be the standard dose, 16 milligrams. But we all know that there are outliers. Some people need less, some people need a little more. But the literature now is saying 24 should be your ceiling. There was a point, and there still is literature out there that says 32 milligrams of Suboxone brand should be your ceiling. But lately, I'm seeing more and more recent literature that talks about 24 milligrams. If they're unresponsive at 24, you really have to reassess what's going on with them, and be real careful. Some patients will tell you they've been on it before and they've been on higher doses. And I've seen patients come into treatment that have been prescribed 64 milligrams of buprenorphine. And what they're telling us when they're in treatment, because we try to get them to be honest, is they're actually selling it. They're diverting it because it's a good source of additional income for those folks. So buprenorphine certainly has a street value, and keep that in mind if you are prescribing it. Now, there are a bunch of different products on the market, and I just have some slides here talking about the different ones and their dosage forms. So SUBUTEX, so there's generic SUBUTEX on the market, which is sublingual tablets. Comes in 2 doses, the 2 milligram and 8 milligram tablets, and the route of administration is sublingual for those tablets. So that is generic. That you can order your patient generic SUBUTEX tablets. Probably should not go with the monotherapy because they can easily be crushed and snorted or injected. If you're going to go with Suboxone tablets. Also, they're generic. Dose strengths also are the 2 and the 8 milligram buprenorphine, and they're in the 4-to-1 ratio with naloxone, and the route of administration is sublingual also for the tablets. We also have the film, Suboxone film, and the trade name Suboxone is Indivior, is the manufacturer of those, and you can see it comes in a number of strengths, 2, 4, 8, and 12 milligram tablets, along with their 4-to-1 ratio of naloxone. Now, the route of administration, according to the drug insert, can be sublingual or buccal, which is between the gum and the cheek. Now, if you're doing induction, it should be sublingual, not use the buccal dose. Don't use that because when the medication is giving buccally, it's absorbed at a different rate than sublingual. So during the induction, always have the patient use a sublingual form. And if they want to do the buccal once they're in maintenance, that's fine. They can do that, but they should be told don't go back and forth because absorption rates are different sublingually and buccally. And as I said, the manufacturer is Indivior. Another product is Subsolv, which is from Orexo. They're making that. and it's the buprenorphine naloxone sublingual tablet. So they recommend sublingual usage, and as you can see, the dosage strengths are a bit different than Indivior's, and that's because they're using a slight variant to the chemical structure, which is absorbed also at a different rate than Suboxone. So the doses available are different. You can see 1.4, 2.9. It can get a little crazy, but it's still in the 4-to-1 ratio for buprenorphine to naloxone. Route of administration, as I said, is sublingual, and Orexo is the manufacturer. And you may inherit patients that are on Subsolv, or you may decide that you want to prescribe that. So be familiar with the different dosage strengths available. BUNAVAIL is buprenorphine naloxone buccal films. These are also films, and again, the dosage strengths are also different from both Suboxone and Subsolv, but still in the 4-to-1 ratio. So you can see the route of administration is Buccal, and the manufacturer is Biodelivery Sciences International. Sometimes a patient may come to you on Subsolv and you want to convert that to Suboxone, or if they're on Suboxone, you may want to go to BUNAVAIL. There are charts available, conversion charts out there in how to do that, and each of the manufacturers, I believe, should have that in their package inserts. You can also get it online too. So when you're prescribing buprenorphine, there's certain things you should look for which are the best candidates and which are the candidates that are not so good for buprenorphine treatment. So the pros are they need to be compliant, or as we would say, adherent to their appointments, to their use of medications for other medical and psychiatric conditions. So they are stably, medically, psychiatrically, they are employed, limited, if any, legal problems, and to me, most important is an intact family and support system. To me, that is one of the most important things, because I always try to get the families involved in the treatment plan and the treatment process for support. So that's the ideal patient there. Now, if they're already in methadone maintenance and they are successful, then don't change them with that. Let them stay in that. They may say, well, my friends are on buprenorphine, but the other things that you need to look at is what's going on with legal problems that they may have about their compliance rates with appointments or medications. If they have no support systems out there, if they've burned all their bridges, if they have extensive psychiatric problems that variably are stable to unstable, they're compensatory or decompensatory, and if they have multiple other substance use problems, these are probably not good candidates for buprenorphine. So you're kind of looking at a risk benefit. So I've given you two extremes here, the ideal patient and the absolute worst patient. Most of your patients are going to be somewhere in the middle. You got to figure out, whether buprenorphine is good for them or not. Sometimes you, because of the extreme situation that they're in, you may be able to decide at the door that they're not good for buprenorphine. Other times, they may be in your program for a period of time, and you're just seeing that either there's no progress or they're taking steps backwards, and there's other problems that are being created. So that type of thing. Now, here's a caveat. If you find out that your patients are diverting your medication, don't automatically make that a detox. Don't fire them from treatment right away. Try to explore and understand what exactly is going on with the patient and how you might be able to resolve that. So always try to resolve the problems that you're running into. Remember, our patients are very impulsive, and they are just coming off of an active addiction, theoretically. And so their impulsivity will continue, and you need to understand that they don't always follow the rules exactly as they're promulgated. So try your best to work with them. Now, I'll be the first to state that you may very well have used every trick in the book and intervention to get them back on track, and it's just not happening, well, then you do need to detox them or send them to methadone maintenance, or send them into treatment, whatever. Obviously, into treatment is first, methadone maintenance may be second. If they refuse all of those, then the only other option may be detoxing them. So you need to figure out what you're going to do with those problem patients. Now, in selecting treatment modalities, some of the things you need to consider, what does the patient expect from treatment? Now, one of the things that I require is not that they come up with a specific date of when they want to be off of it, but they can, I want them to be able to picture themselves not on the medication and what their life will be like not on the medication. And that's something that I stress with them and point out every time I see them. And I don't put pressure on them for ever coming off the medication. That's a process between the patient and the prescriber. And the patient has probably a greater risk there, so we give them more of that responsibility. What are their goals while they're on the medication? That's most important, that up front you set specific goals for, okay, now you're on the medication, we're stabilizing you, you are utilizing healthy coping mechanisms. What is going to happen now in your life? So you need to have those set, and you need to have them measurable, and you need to measure them every time you see the patient. Utilize the stages of change as to where they are when you see them, as far as pre-contemplation, contemplation, preparation, all the way up, and utilize interventions based on their stage of change. What are the current psychosocial circumstances around them? Do they have housing? Are there legal problems? How's their support system? Is there marital discord? All that kind of stuff. What resources are they utilizing? What resources do they have available? Know what their past history of treatment outcomes has been, because we deal a lot with multiple relapsers in this business, and each time the patient comes into treatment, we want to make sure that we're doing something different than the last time. It didn't work the last time or the time before that. What's going to be different this time? So that's important, that you understand what happened the last time they were in treatment. It doesn't have to be on buprenorphine. It just could be drug and alcohol. It could be methadone maintenance. It could be a number of other things. But what actually went wrong? What was that process of relapse that happened? And then evidence regarding safety, efficacy, and effectiveness of the medication. We always look to see what dosage of medications they were on. In psych, I see patients that will tell me up and down that they've been on every psychiatric medication, it's not working. And when I further explore, I find out that they were prescribed subtherapeutic levels of medication, and for very, very short periods of time. And when the patient gets a tinge of a side effect, they stop taking their medication rather than figuring out what we can do to neutralize the side effect. And then informed consent is most important with these patients. So not only the risks, the benefits, the alternatives, the side effects, all of that, you need to make sure that the patient knows that. Now, as far as the pre-induction protocol, so there are several protocols out there. You can find them online. This is just one that I utilize. Prior to induction, consideration should be given to the type of opioid dependence, whether it's long or short acting. Now, today, the only long acting opiate is methadone that's out there. Every other medication, they can figure out how, even though it is prescribed as long acting, it can be made short acting, either by crushing or by other chemical means. They're very good at figuring out people addicted to opiates, especially those that are biochemists, can figure out how to bypass the long acting action of those medications. Obviously, we need to know the time since they last used the opiate, because we want to see them in withdrawal and objective withdrawal, not just subjective, to make sure that the full agonist opiates are falling off the receptor. If we give buprenorphine while the full agonist opiates are still on the receptors, the buprenorphine, because it has a higher affinity, will rip the the full agonist opiates off the receptor, and the person will go into precipitated withdrawal, which has been covered in several other of these webinars, so I'm not going to go into that. Now, here's an interesting thing for those squeamish people or those risk-aversive people. Gradual induction over several days has led to a high rate of dropout during the induction period. Now, the literature has been replicated on this. So, if the recommendation is that you should get adequate maintenance dose titrated to clinical effectiveness as rapidly as possible. Again, remember, our patients are intolerant of cravings, and they are very impulsive. So you want to get their cravings to a minimal level, if not eradicate it, as fast as possible. That's why today they say by the second day you should be giving them their 16 milligrams rather than waiting to the end of the week. Because these people, if you're deciding that your induction is going to be a week, these patients aren't going to hang around for a week, believe me, because they're going to start having cravings. Especially those that have been using a lot of opiates. So day one, a total induction dosage of equivalent of 8 milligrams of buprenorphine, and I'm using Suboxone as the dosage standard here, and start with an initial dose of 2 or 4 milligrams. So the literature will utilize both, either 2 or 4. I use 4 to start, and then I give them another 4 a couple hours later, so that they have 8 total. And so they come in, we do a short history, a urine drug screen, and go over all the paperwork and understanding, and give them copies. Give them 4 milligrams, have them sit in an area, specified area, for a couple hours, and then give them another 4, and then have them sit for no more than an hour, not necessary, and they can go. And then you have them come back the next day, and you can give them 16 milligrams in a single dose. You can divide it if you want to 8 and 8 over a 2-hour period, but I've not had any problems with 16 milligrams. Target dose is 16 milligrams for the Suboxone sublingual, but there are other equivalents there. So for Subsalv and BUNAVAIL, I give you the recommended target dose, but you can, as I say, these charts are available comparing one to the other, because it can get a little hectic and hairy. Actually, Indivior gives a nice chart for all of them, but I'm sure they all do. Upper limits, 24 for Suboxone, 17.1 for Subsalv, 12.6 for BUNAVAIL, and that's all in their literature there. Now, as far as scheduling office visits, during the induction period, it's recommended that the initial dose be provided under supervision. So you can either have the medication in your office, you can give them a script for 2 days worth to bring to your office, or even 1 day, depending on how you want to do it, where they go to the pharmacy, get it filled, bring it to you, and you give it to them. In the event that they get it filled and not come back to you, then they only have a 1 or 2 day prescription, which chances are they're going to come to you anyway, rather than go out and try to sell a day's worth. It's not really going to be worth it unless they have access to multiple providers. No more than 1 to 2 days of product for take-home use should be provided in each of the 2 or 3 visits during the first week of treatment. Patients should be seen at reasonable intervals. Now, that is a very broad guideline, reasonable intervals, which means they're leaving it up to you based on what you are seeing. At least the recommended practice guideline is at least weekly during the first month, based upon individual circumstances. And provision of multiple refills is not advised early in treatment or without appropriate patient follow-up visits. So generally, when you're writing, after you feel comfortable, at the end of a month, you can give them a prescription for a month with no refills, have them come back in a month. If they are in therapy, hopefully they are, make sure you have good connections and releases from the patient to talk to the therapist, and vice versa, about how they're doing. Are they coming in for their sessions, that type of thing. and periodic assessments necessary to determine compliance with dosing, the effectiveness of the treatment plan, and the overall patient assessment. So make sure that you're documenting all of that and you're very prudent in what you're documenting. Once the stable dose has been achieved and toxicological tests do not indicate illicit drug use, less frequent follow-up visits may be appropriate. Again, that's up to you. Once monthly visit schedule may be reasonable, but you may want to make that longer, especially if they're doing really well in therapy and they're going as prescribed. You can, just like any other Schedule 3, you can give multiple refills if you want, but I wouldn't do that early in treatment. That's going to be up to you. Now, some modification information. First of all, you need to evaluate the absence of buprenorphine toxicity, which is rare, by the way, since it's a partial agonist. But you're going to be looking at the patient. Ideally, you're going to be collecting collateral information from either the therapist or responsible family member, any absence of medical or behavioral adverse effects. Most important that you document pertinent negatives, that things are not present, responsible handling of buprenorphine-containing products by the patient. So you want to see, ask them, how are they storing, how are they handling, what are they doing with their supply, their compliance with all elements of the treatment plan, such as their continuance in recovery-oriented activities, psychotherapy, other psychosocial modalities, 12-step support, family work, that type of thing. Abstinence from illicit drug use, including problematic alcohol or other benzodiazepine use, any of the depressants. Most important that you watch those folks. If treatment goals are not being achieved, reevaluate the appropriateness of continued treatment. So you should be reevaluating that every time you see the patient. Your conclusion should always be continue treatment or discontinue treatment. That really has to be your plan for the patient. If you've concluded the patient really is chronically non-adherent, assess whether to refer the patient to a specialist or a more intensive behavioral treatment environment, as I mentioned before. And your decision should be based on the treatment plan established and agreed upon between the two of you, that you and the patient at the beginning of treatment. One of the places where you can find really good contracts are the pain management folks. They really are experienced at generating behavioral treatment contracts with the patient, so you can get those things. They're available online. Your drug rep should be able to get you some specific for opiate treatment. But if you don't have access to any of that, find out from the pain management folks. They really have some good checklists and contracts and that type of thing that are readily available. Patients who want to discontinue treatment, they should be advised not to change the dose of buprenorphine without consulting you. They should be apprised of the potential to relapse should they discontinue, especially if they want to discontinue early. If a dependent patient abruptly discontinues the product, an opiate abstinence or withdrawal syndrome may develop. Now, we know with buprenorphine, it's milder than with a full agonist opiate, but they'll still go through withdrawal. And when people that have a opiate addiction begin to get the initial twinges of withdrawal, they want to replace the opiate so that the withdrawal will stop. So then we have relapse. Make sure if you are going to discontinue that you taper the dose rather than abruptly discontinuing, and you can provide a dose reduction schedule. Preventing diversion and abuse is another big issue. Initiate treatment with supervised administration. Make sure you check the applicable state prescription drug monitoring programs. Now, in Pennsylvania, we're required to check the online prescription drug monitoring program every time we write a prescription. So Sorry about that. Make sure that you've done that. Make sure you follow whatever your state guidelines and statutes say about the prescription drug monitoring program and when you have to check it. Have a plan to deal with patient requests for replacement of prescriptions or supplies of medication that are described as lost or stolen. Make sure you make that clear up front what you're going to do with that. Keep tight control of your prescription pads. If you're writing regular prescriptions, ideally you can do them electronically, but if you have pads, make sure you don't have them where somebody can get their hands on them. And then the guideline says write all numbers, quantity and strength. That shouldn't be quality, it should be quantity and strength in both numbers and letters, like you would write a personal check, so that they can't be altered. Psychosocial counseling is an essential component, obviously, should be strongly encouraged. And here is some additional information that when the slides are posted online, you can certainly access any of these websites to get additional information. And that's it. I'm right on time, I guess, for any questions that you may have written. Al, Robert, any questions coming?
Okay, Al, it looks like you got disconnected somehow, so go if you want to, we'll wait for him to sign back in. But anyone else, if you have questions, if you can see the chat bar, please use the chat bar to type them in. And I also activated a question section. If you can't see the chat bar, you can use the question section as well. And it could be billed if they can't see the chat, so if not, I open the questions as well. So go ahead and type them in either place if you want, attendees. Okay, let's see here. Okay, there's some questions coming. Can you see the questions, Bill? You want me to read them out?
Let me see if I can open the box. Let me see.
Yeah.
I can see. Okay. Video webinar. I'm looking in the chat and I'm not seeing any questions. I see everything that you've put in. And
yeah.
I don't.
Okay.
I'll
go ahead and read them down. That's okay. The first one I'm not quite sure of. It just says marijuana use. Do we continue TX? I don't know if that means he's in Texas or
treatment.
Or what,
that means treatment. That
okay.
means treatment. If they're using, again, that's up to you. Are they using it medicinally? Are they in a state that allows it? Basically, we tell folks that we don't want them on any controlled substance, including marijuana. You know, what we've just last week actually, we had a patient that was getting Suboxone, and he was using K2 spice, which is the synthetic marijuana, and he had a complete vasovagal reaction in which every blood vessel in his body dilated. Naturally, he went into a faint. He turned completely blue. He had no pulse, no blood pressure. We did a sternal rub with him. They were getting ready to actually they were getting ready to start CPR on him, and he began to come around. But that was quite interesting. So we're always worried about other substances that they're using. They may think they're smoking pure cannabis, but it may be either laced with or may be K2 or spice. So therein lies the problem with that. So we basically tell them, no, you shouldn't be on anything else for your own safety.
Okay, next one. Where can I do the 24-hour course?
Okay, you can go online for the American Academy of Addiction Psychiatrists and access it there. You may be able to access it through APNA's website. I don't know whether you can. I did mine through the American Association of Nurse Practitioners, but with ASAM, which initially was a bit difficult to access and finding it if you were to log off. But the American Academy of Addiction Psychiatrists, they should have a link directly to the training. So that's AAAP.org, I believe.
Okay. Do you recommend people who stop Suboxone to change to Vivitrol?
Again, that's up to them. I certainly talk, when I'm talking about medication-assisted treatment, I look at all the options, including Vivitrol, buprenorphine, and even the naltrexone tablets and Camprol together, doing that. It really depends. It really needs to be individualized with the particular patient, how well you know the patient, what the patient's telling you about themselves, that type of thing. But yeah, you shouldn't just stop. If Suboxone's not working, or they don't want to use it, or they've decided that they want to come off of it, certainly consider Vivitrol rather than nothing. Absolutely.
Okay. What if a patient loses the RX and is in withdrawal?
See, that's again, if they're in withdrawal, what I generally do, just so you know, I give them one get out of jail free card, which means I will give them another chance, assuming, give them the benefit of the doubt. If not, if this continues, then you give them weekly prescriptions rather than monthly or that type of thing. The other thing is, if you give them weekly, they're not going to go into withdrawal so fast anyway. But really really push what they're doing with their medication, what they're doing with their prescription. A lot of places like to do it electronically or calling in the prescription. You can certainly look to doing that if you want. But the patient, you shouldn't be punishing the patient initially. So they're going into withdrawal. Give them a benefit of the doubt the first time. At least that's what I do. Nobody's saying that you have to do that. But what we really want to do is make the whole treatment a success rather than punishing the patient for walking down the wrong street or something like that.
Okay. What does the DEA usually request when they spot check?
They want to see your documents. They want to see your counts. They want to know, oh, this is another thing, getting the patients to use the same pharmacy is probably good. They're going to want to know if you keep tabs on that, what pharmacy they use. A lot of places, like especially we learned this from the pain management folks, that they agree to only use one pharmacy so that you can get that information should you need it very rapidly. And the DEA will look to that information. Now keep in mind that with the prescription monitoring programs, that information for the prescriptions are on file, and the DEA can collect that easily now, so they know what prescriptions you are writing, so they can check that against what the records you have, and they better be the same or there'll be problems, guaranteed.
Okay. How long do you keep one on Suboxone? I've seen people on it for years.
Yeah, there technically is no requirement for how long you can be on it, just like with methadone. As I say, I talk to my patients about seeing the light at the end of the tunnel and what that would be like, and where they have to be in order to begin thinking about coming off. So I want them to be thinking about what it would be like, where they need to be not on the medication, and not come up with a date. But if you work on that proactively, I think you're going to see them a shorter time, especially if you're monitoring progress.
Okay. At a detox facility, the patient receives buprenorphine. Is it all right that they receive Suboxone as their next dose?
Could you read that again?
At a detox facility, a patient receives buprenorphine? And then the question is it all right that they receive Suboxone as their next dose?
Yes. Yes, that's fine.
Okay. How do you handle it if a patient is being prescribed benzos by another provider? Do you wait until they are off?
Okay, let me, before I answer that, let me go back. I want to modify the answer to that question. Usually in detox, they start at a higher dose and taper them down once they see withdrawal. But the general rule is, before you can start maintenance, the patient has to be off a full agonist opiates for a minimum of 10 days. So if their last use of the full agonist opiate was less than 10 days, you should probably start them low, and probably, now hopefully they won't be having cravings. You may want to take them out till at least 10 days before you get them up to the 16 milligrams of when they say their last use of their oxys or heroin or perks or whatever it was that they're using. Now, the next question, could you read that again, Robert?
Okay. How do you handle if the patient is being prescribed benzos by another provider? Do you wait until they are off?
No, I don't wait. I do personally talk to the prescriber to tell them why I would like to see them tapered off of the benzo, and have them try to use a alternative if they're suffering from anxiety. But you know, truth be told, if they're getting from a prescriber benzos and they're opiate dependent, chances are their anxiety is coming during periods of withdrawal, and they're not telling the prescriber that. Or if they are, the prescriber doesn't know that opiate withdrawal can produce anxiety. So I try to explain that to the prescriber and tell them that it's best practice to get the patient off of a controlled substance, and either get them off completely or give them an alternative non-addicting anxiolytic, you know, an SSRI. Inderal I use a lot. The atypicals, antipsychotics at low dose for their anxiety if it's that impairing.
Okay. You said 2 of 4 milligrams on the first day. What do you give on the second day? 2 of 4 milligrams again for a total of 16?
No, I'll give them either 16 milligrams at one sitting, or I'll give them 8 and 8. I'll give them 8 milligrams and then wait an hour, hour and a half, and give them the second 8 milligrams, wait another hour. But usually I just give them the 16 and they're fine.
Okay. This one's a little bit longer. I have a client on induction at 8 milligrams, and it has been 6 days. She has felt fine, but now feels some withdrawal symptoms. Do you typically need to adjust in the first 2 weeks?
Yeah, you always want to adjust whenever they report cravings or withdrawal. And I can't imagine why they would be having withdrawal unless there was still full agonist opiates in their system. But we always look at cravings, and we want to eliminate that. That's our primary focus, is eliminating cravings. So when you see them and they say, I'm having cravings for heroin or whatever, up the dose.
Okay. How are you handling cocaine use during treatment, and for how long?
Now, see, that's when if they are continue to use cocaine, they really need to be referred to an addiction specialist, and there has to be a plan to getting them to stop the cocaine. They really shouldn't be, because, you know, our patients are better psychopharmacologists than the best psychopharmacologists that are out there. They know about the cocktail dosage of how much cocaine to how much buprenorphine to how much heroin, and all of that. So they really need to be off of the cocaine. Remember, the whole purpose of medication-assisted treatment is to get them to become, you know, progressive and productive people in the community with their family. If they continue to use cocaine, then chances are that's not happening. So we got to get them off the cocaine.
Okay. Is it correct to say that prescriber must write or have otherwise printed their XDEA license number on the prescription?
Well, you know, we're taught that when we write a prescription for a controlled substance, we have to include our DEA number. Best practices today is that you write on your prescription pad to the pharmacist to call you for the number. That way the patient doesn't have access to the number either, that nobody does. And so a lot of my colleagues do that. They write on the prescription, call my office for my DEA X number, and they can do that.
Okay, how do you write the RX for the induction?
Again, that depends. You can write it just as you're going to do the induction, or you can give them a total number of strips that they have to bring to your office for the length of the induction, or you can send them to pick up daily prescriptions. However you want to do it, you can do it. Doesn't really make any difference. A lot of folks that I know write the prescription for the full induction. So, you know, what you're going to need for the full induction, plus assuming that for a full week, actually, if you trust the patient for a full week, then you can write for the full week to bring to the office so that you can begin doling it out. But remember, if you're keeping it in your office, you have to have it locked up. And if you know, remember the rule that if you are supplying the buprenorphine like in a facility, that's not part of the 30. But when you're doing the induction, it is part of the 30. Even though you've written a prescription and you're doling it out, and your plan is to write another prescription. So it's best to start counting them as part of your 30 that you have. But you can don't write for any more than a week though to bring to you if you want to do that. A lot of people only do 2 days and they give them a prescription for the rest of the week, and then they come back and you know at the beginning of the next week for another week's prescription or 2 weeks prescription, however you want to do that.
Okay. Well, it's a couple minutes after 12, so I've got a list of all the questions that were asked. So we'll, within a day or two, or as soon as we get the answers of all the questions in, we'll post them on the webinar archive on the INSA website. So give us a day or two to get the answers typed up, and we will have those available to everyone. Al, are you on? Did you have anything else you wanted to say?
I wanted to thank Dr. Lorman for his great presentation. Remind everyone to complete your evaluation when you receive it. You'll also receive an evaluation 30 days post-conference. If you could fill that out as well, that's to meet the intent of the PCSSO grant with the American Academy of Addiction Psychiatry. And again, thanking the staff of the International Nurses Society on Addictions for sponsoring this webinar. Have a great week, and we'll see you at a future webinar.
Okay, thanks everyone.